بسم الله والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم تسليما كثيرا. Inshallah, today we are going to discuss some of the pediatric endocrinology review MCQs. This is part 3, and to remind everybody, these MCQs are only for education, not actual examination MCQs. My name is Abdulmoein Al-Agha, Professor of Pediatric Endocrinology, Faculty of Medicine, King Abdulaziz University, Jeddah. First MCQ, 6-year-old boy presented with obesity, mental retardation, subcapsular cataract. On examination, his hand photo. So, number one question for you, what do you think abnormalities are available in the photo? What do you think? Yes, short fourth metacarpal. Correct answer. Okay, now the second question, what do you think will be the diagnosis? Combination of short fourth metacarpal, obesity, mental retardation, and cataract. What do you think? These combinations are under which diagnosis? Yes, pseudo-hypoparathyroidism. Correct. So you have to think about this one before you answer the statement of the question. Which one of the following is expected laboratory finding? So, i.e., what biochemical abnormalities found in pseudo-hypoparathyroidism? So, low calcium, low phosphates, wrong, because here parathyroid hormone is normal or elevated but does not work on the receptor. So, same biochemical findings of hypoparathyroidism. The only difference between hypoparathyroidism and pseudo-hypoparathyroidism, in hypoparathyroidism, parathyroid hormone is low. In pseudo-hypoparathyroidism, parathyroid hormone is high, but other biochemical findings the same. So we expect with hypoparathyroidism to have low calcium and high phosphate. Low calcium and high phosphate. Pseudo-hypoparathyroidism was described by Dr. Fuller Albright, 1942. It's a combination of clinical and biochemical abnormalities. Clinical anomalies or abnormalities include short stature, rounded face, short fourth metacarpals of the hand and feet, obesity, dental hypoplasia, and soft tissue calcification. Cataract or subcutaneous calcification or intracranial calcifications all could happen in pseudo-hypoparathyroidism. Results from end organ resistance of parathyroid hormone receptors in the kidney and in the bone to parathyroid hormone. That's why the parathyroid hormone level is high, and despite parathyroid hormone is high, we have low calcium and high phosphate. It has many subtypes: type 1A, type 1B, type 1C, type 2, and pseudo-hypoparathyroidism. The commonest subtype is type 1A. And in this type, we have combination of clinical and biochemical abnormalities. Type 1A is the most common type and represents about 70% of all cases of pseudo-hypoparathyroidism. But remind you, not in all subtypes of pseudo-hypoparathyroidism there is clinical manifestations of, for example, obesity, short stature, mental abnormality. Sometimes we have a normal person, only abnormal biochemical findings of low calcium, high phosphate, high parathyroid. That is typical example of type 1B and type 2. They don't have any clinical manifestations. 13-year-old girl presented with obesity, and her fundal examination was abnormal. The question for you, what abnormalities you are seeing in this photo? What do you think about this retina? Think about it. Yes, there is abnormal pigmentation of the retina, and that is what is called retinitis pigmentosa. The second question for you, obesity and retinitis pigmentosa. Which of the following syndromes you think is the diagnosis? Prader-Willi syndrome? No. Lawrence-Moon-Biddle syndrome? Yes. This is the classical symptoms of Lawrence-Moon-Biddle or Bardet-Biedl syndrome. There are two different names for the syndrome, either Lawrence-Moon-Biedl or Bardet-Biedl. Bardet-Biedl syndrome, all the same. They have combination of obesity and retinitis pigmentosa. Bardet-Biedl syndrome is autosomal recessive syndrome characterized by retinitis pigmentosa, obesity, and there is something else important to look for is post-axial polydactyly. They tend to have polydactyly, and the type of polydactyly is post-axial. Sometimes they might have renal dysfunction, sometimes they have learning difficulties and hypogonadism. The diagnosis of Bardet-Biedl syndrome is usually clinical, but sometimes we confirm it by doing genetic testing. This is what looks like the retina, retinitis pigmentosa, and on the right side of the slide, the post-axial polydactyly, whether in the hands or in the feet. 3-year-old girl with delayed motor milestones and learning disabilities. Her perinatal history was normal. Mother reported that her daughter was floppy in first year of life with poor feeding. So this girl, in the past history, she was floppy, she was hypotonic, she was having poor feeding, not now, only in her first year of life. Think about this statement. Don't ignore it. Don't take it lightly. She had past history of hypotonia, poor feeding, and first year of life. Now she's obese with delayed motor development. On examination, her weight above 99 percentile, height was on 10th percentile, relatively short. She had short, stubby fingers and almond-shaped eyes. Almond-shaped eyes. All these conditions or these anomalies, what do you think will be the diagnosis? Think about these combinations. Yes, these combinations are classical finding in Prader-Willi syndrome. Prader-Willi syndrome. The question in Prader-Willi syndrome, what is most likely genetic cause? And the answer will be C. 25% of cases of Prader-Willi syndrome, they have two copies of chromosome 15 comes from mother. You know, we should have one copy from father, one copy from the mother. Here, two copies. came from the mother, and that is what is called uniparental disomy. Disomy means two, uniparental from one parent. In Prader-Willi syndrome, from the mother. In Angelman syndrome, the same thing happened. Chromosome 15, two copies, but comes from father. So Prader-Willi from the mother, Angelman syndrome from the father. Prader-Willi syndrome, one of the characteristic features, in their first year of life, they tend to have hypotonia and they don't feed very well. Sometimes they need NG feeding and their development will be slow in first year of life. Then the opposite will happen when they get older. Above 2 and 3 years of age, they start to eat too much, always hungry, always looking for food. Why? Because they have hypothalamic deficiency. Of what? Number one, of satiety center. They don't feel full, always hungry. And they have defect in the hypothalamic releasing hormones. Can you give me example? Yes, they have defect in the release of gonadotropin releasing hormone from the hypothalamus. That's why they are at risk of hypogonadism. What else? They are at risk of deficiency of growth hormone releasing hormone from the hypothalamus. They are at risk of short stature and increased fat to lean tissue ratio. In addition, they have mild to moderate intellectual impairment. They have behavioral problems. They are aggressive. They could steal food from their colleagues. They could also steal food from the neighbors. They are having behavioral aggressiveness. In addition, they have dysmorphic features of narrow forehead, small hands, small feet, short stature, and obesity. When we do genetic testing for them, looking for confirmation of Prader-Willi syndrome, in 75% of cases, we could find deletion of chromosome 15 comes from the father. So father's chromosome 15 deletion. In the remaining 25%, as I mentioned previously, there is uniparental disomy chromosome 15. The same thing happened in Angelman syndrome, but the two copies of 15 chromosome number 15, comes from father in Angelman syndrome. What are the genetic syndromes associated with childhood obesity? Number one, Prader-Willi syndrome. Number two, pseudo-hypoparathyroidism. Number three, Lawrence-Moon-Biddle syndrome. I think you have to read all the three syndromes very carefully, common in clinical practice, and you have to rule it out in any childhood obesity. Syndromatic causes of obesity. You have to think about these syndromes. In addition, we might have less commonly Cohen syndrome, Down syndrome, and Turner syndrome. 11-year-old boy presented with truncal obesity, striae, hypertension, and osteoporosis. What do you think these combinations fit which diagnosis? Yes, this is classical combination of Cushing syndrome. You are right, Cushing syndrome. The question, Which one of the following is the commonest cause of Cushing syndrome? And the answer is adrenal adenoma. You have to differentiate between Cushing disease and Cushing syndrome. Cushing disease, when we have ACTH dependent Cushing syndrome. That means the problem from the pituitary, from the ACTH. So if we have high ACTH, that is disease. If we have adrenal source of high cortisol, that is syndrome. So we have Cushing disease and we have Cushing syndrome. In Cushing disease, ACTH dependent. Cushing syndrome, ACTH independent. In ACTH dependent Cushing syndrome, most of the cases, Cushing disease comes from high ACTH secretion from pituitary, for example, adenoma, pituitary adenoma. Or we could have ectopic ACTH secretion, for example, small cell carcinoma of the lung. Or we could have ectopic CRH excretion. While in ACTH independent Cushing syndrome, that is the problem, comes from the adrenal gland, the commonest cause of adrenal pathology is adenoma, adrenal adenoma, followed by carcinoma, and rarely micro or macronodular hyperplasia of the adrenal gland. And this picture showing exact features, clinical features of Cushing syndrome. You could see the slide is very clear combination of many clinical anomalies in Cushing syndrome. A 10-year-old boy with Cushing syndrome presented acutely in the emergency room with Addisonian crisis. This is a child with Cushing syndrome, a real Cushing syndrome. Not mistakenly, the diagnosis was true, Cushing syndrome. And we know Cushing syndrome, they are having hypertension, not hypotension. This child came to the emergency room with low blood pressure, with hypovolemia, dehydration, Addisonian crisis. So the question asking you, what's happened? Why? How come Cushing syndrome comes with Addisonian crisis? Should not be. If we think about it, should not be, because this is a Cushing, totally different from Addison, completely 180-degree different from Addison, the opposite of Addison. How come we could find Addison or Addisonian crisis in Cushing syndrome? A, this is impossible, as diagnosis must be inaccurate. This is false. The patient should be reinvestigated again. Might be, but we are sure this is the diagnosis of Cushing syndrome was true. The patient should be treated as Addisonian crisis? Yes. Because he presented Addisonian crisis, we have to treat as Addisonian crisis. Then, if there is any doubt about the diagnosis, then we reinvestigate. The patient is likely to have mixed pituitary tumor causing both conditions? No, cannot be. So the answer is C. So, what's the explanation of Addisonian crisis in a child with Cushing syndrome? The most common cause of Cushing syndrome, as you know, is prolonged exposure to steroid. For example, a nephrotic syndrome child taking a steroid. And you know, for example, in nephrotic syndrome, during the relapse, the patient should take the steroid, and then the nephrologist start to wean down and taper down the steroid. Sometimes, if the tapering of the steroid was not enough, or there was a hurry in reducing the dose of steroid, the axis, hypothalamic pituitary adrenal axis, is still suppressed because it takes at least 4 to 6 weeks for this axis to recover from suppression of exogenous steroid. If the tapering was rapid, or the patient compliance, they stop the steroid all of a sudden, then the child is at risk, high risk of developing Addisonian crisis, secondary adrenal insufficiency, not primary, secondary adrenal insufficiency. 11-year-old girl has presented with headache associated with hypertension. So here we have a girl with headache and hypertension, in addition to hypokalemia metabolic alkalosis. All these combination of what? Is it because of diuretic therapy? Wrong. Diuretic therapy makes blood pressure low. In fact, diuretic therapy is one of the medications to treat hypertension. So this child is having hypertension, so this is wrong. Bartter syndrome and Gentleman syndrome, both of them, they have hypokalemic alkalosis, but they don't have hypertension. Cushing syndrome is the right answer. In Cushing syndrome, primary hyperaldosteronism, where we find high blood pressure, low potassium, metabolic alkalosis. The right answer is Cushing syndrome. Cushing syndrome, classical clinical symptoms of Cushing syndrome is hypertension and biochemically hypokalemic alkalosis. The most common cause of primary hyperaldosteronism, number 1, adenoma, aldosterone producing adenoma, or number 2, bilateral adrenal hyperplasia, number 3, unilateral adrenal hyperplasia, number 4, aldosterone producing carcinoma, or ectopic aldosterone producing tumor. All these are the causes of primary hyperaldosteronism. 16-year-old boy presented with gynecomastia. Which of the following medication could be the cause? Does hydralazine or tamoxifen or spironolactone or danazol? Spironolactone is a diuretic. In addition, this medication has anti-androgenic activity. So it is good to treat hyperandrogenism, especially in females with polycystic ovary syndrome. One of the medications we prescribe to them is spironolactone or aldactone. Aldactone is a trade name. Why? Because it has anti-androgenic activity. So if the boy or a man takes spironolactone for long period, they are at risk of decreasing level of androgen, and when their androgen level is reduced, they are at risk of gynecomastia. And this is the list, big list of medication could cause gynecomastia. So whenever you have a child, adolescent, adult with gynecomastia, you have to take medication history. Very important to ask for medications because there is plenty of medications could cause gynecomastia. Another boy, another adolescent with gynecomastia, 15 years of age, presented with tender gynecomastia. He is completely healthy. In examination and in the history, nothing significant, no medication history. His examination, his genitalia doesn't have hypogonadism, completely normal genital examination, but he has gynecomastia. As you can see in the photo, significant gynecomastia despite everything is normal in the history, in the examination. So the question, which one of the following is first option in the management? Do you want to start treatment with anti-estrogen? Because gynecomastia, not the physiological one, the pathological one of the medication of pathological gynecomastia is anti-estrogen, because as you know, breast tissue is dependent on estrogen in both sexes. So when we have a boy or a man with breast tissue, we could use anti-estrogen. But in this child, we should not use this medication because this child does not have pathological gynecomastia. He has physiological gynecomastia. Number 2, treatment with aromatase inhibitor. Yes, that is good in pathological gynecomastia, not in physiological gynecomastia. So the first two medications, usually we use them in pathological gynecomastia rather than physiological gynecomastia. Number 3, surgery. Yes, but not in the physiological gynecomastia and pathological. So for your information, the first 3 choices are good choices, are true choices, but not in physiological gynecomastia. So the answer of this question is reassurance. Why did I say this is a physiological gynecomastia? Because he's completely normal, completely healthy, normal history, normal examination, and he's in the pubertal surge of hormone. When we have plenty of testosterone during puberty, surge of testosterone, some of this excessive or high testosterone, high physiological testosterone, converted into estrogen by aromatase enzyme. That's why they develop gynecomastia. But what will happen after that? It will take about 2 to 3 years. Then regress and the child will have nothing. Opposite to the female, where their breast keep increasing in the staging of breast development, here there will be sort of regression after 2 to 3 years. And that is what is called pubertal gynecomastia. It's present in about 60% of males adolescents during puberty. Let's discuss what is physiological gynecomastia. Gynecomastia is a breast enlargement in males. It could be for physiological causes or could be pathological causes. We have in our life 3 stages where we could have physiological gynecomastia. Number 1, neonatal gynecomastia. Neonatal gynecomastia is physiological process because the neonate during pregnancy, some of the maternal estrogen and maternal sex hormone through the placenta transported to the baby, to the fetus. So after delivery, some of these hormones estrogen will be making breast tissue in the neonate. And that is what is called neonatal gynecomastia. In neonatal gynecomastia, we should not do anything. We should not investigate, only reassurance and follow up in the clinic. The second physiological cause of gynecomastia, as I mentioned, pubertal gynecomastia. And the third physiological gynecomastia in our life in elderly patients above 65 years of age, when they start to have hypogonadism because of age, when their testosterone level getting less, they will have physiological gynecomastia. So you have to think always, whenever you have gynecomastia, is it a physiological gynecomastia or pathological gynecomastia? Gynecomastia is a benign proliferation of glandular breast tissue in males. So this terminology should be only for males. Pubertal gynecomastia is common from puberty to the age of 25. The good thing, it resolves spontaneously without any medication, without any surgery. It is most likely due to conversion of testosterone to estrogen by aromatase enzyme, and that is what is called aromatization of testosterone. When you read about something called aromatization of testosterone, that means conversion of testosterone to estrogen by aromatase enzyme. And everyone with gynecomastia, you should take good history, good examination to differentiate is it a physiological or pathological. These some of the history tips in the slide. You could read it. Important to ask in any male with gynecomastia. 16-year-old boy noted to have firm mass behind the right nipple. So here, another adolescent with mass firm, small behind the nipple. The mass is mobile, non-tender. Select the most likely diagnosis. Is this mass because of lymphoma, intraductal papilloma, gynecomastia, benign cyst? What do you think? This mass, firm mass behind the nipple. What could be one of these differential diagnoses? The answer is C, gynecomastia. This is the classical description of breast development, initial stages of breast development, whether in males or females. When breasts start to develop, usually it looks like a small mass behind the nipple. So always be careful not to further investigate any child like this. And I have seen some cases referred to me for second opinion because the doctor decided to take biopsy from this mass. No, this mass is during puberty, during breast development. This is the classical description of breast tissue. But if it happens any time, not in puberty period, not in adolescent period, yes, you have to think of other differential diagnosis and you have to investigate and do biopsy. But when it presented during puberty, this is the classical description of breast development. Gynecomastia is a benign enlargement of male breast, usually bilateral but sometimes unilateral, resulting from proliferation of glandular component of the breast. And during examination, you have to feel the breast tissue. Is it a real breast tissue or a fat tissue? Because obese patients have fat accumulation in breast tissue. When only fat accumulation rather than glandular proliferation by hand examination, by hand palpation, so we call it lipomata. Lipomata means pseudogynecomastia, and means that there is no real gynecomastia. It is pseudo, it is false, it's only fat. So the only treatment for this is just losing body weight. 7-year-old boy presented with vomiting, constipation, lethargy, and polyuria. There was no dysmorphic features. Calcium was high. There was hypercalcemia and phosphate low. Urine calcium creatinine ratio was high. parathyroid hormone was high. Vitamin D normal. So, what do you think the diagnosis? Think about it. The diagnosis is primary hyperparathyroidism. The question, which one of the following is most likely cause of primary hyperparathyroidism? The answer is parathyroid adenoma. Parathyroid adenoma. But the other differential diagnosis, A, B, C, all are causes of hypercalcemia. So this slide is educational. If somebody asks you what's the differential diagnosis of hypercalcemia in children, you mention all these four. But in Williams syndrome, usually it is transient hypercalcemia, usually associated with dysmorphic features. So this child at 7 years of age, if in Williams, there will be no hypercalcemia at 7 years of age because it is transient. And in Williams, there will be dysmorphic features. Here in the question, no dysmorphic signs. In familial hypocalciuric hypercalcemia, there is mutation of vitamin D receptor, calcium sensing receptor, not vitamin D, calcium sensing receptor. In this condition, the urine calcium creatinine ratio will be very low and sometimes undetectable or very low. Here, urine calcium creatinine ratio was high, not low. So we cannot, it's against number B. It's against hypocalciuric hypercalcemia. Here we have excessive excretion of calcium in the urine. Hypervitaminosis D, yes, it is one of the good causes of hypercalcemia, but in the question, vitamin D was normal. So the only thing in this question is parathyroid adenoma causing primary hyperparathyroidism. Hypercalcemia in children, it may present with hypotonia, poor breathing, vomiting, constipation, abdominal pain, lethargy, polyuria, dehydration, failure to thrive, and seizure. Please remember all these symptoms and signs. You have to ask and look for all these symptoms in any child with hypercalcemia. And in severe cases of hypercalcemia, there will be renal failure. Why renal failure? Because of nephrocalcinosis and acute pancreatitis, secondary to acute hypercalcemia. In adolescent, hypercalcemia may cause psychiatric problems. Hypercalcemia causes could be divided into two categories, either parathyroid hormone dependent or parathyroid hormone independent hypercalcemia. In parathyroid hormone independent, which is the commonest category in children, most of the cases of hypercalcemia in children is parathyroid hormone independent. That means we don't find high parathyroid hormone. There are good causes in this category. Number one, high vitamin D level, or granulomatous disorders, or idiopathic infantile hypercalcemia or Williams syndrome. While in parathyroid hormone dependent hypercalcemia, the good example is primary hyperparathyroidism due to adenoma, or tertiary hyperparathyroidism due to chronic renal failure, or during treatment of hypophosphatemic rickets. Otherwise, healthy 6-week-old infant presented with generalized seizure. She was somewhat sleepy, but normal examination. Her glucose was normal. Sodium was normal, calcium was very low, 1.5. So the cause of seizure here is because of low calcium. And phosphate is high. So here we have low calcium and high phosphate. Magnesium was normal. Alkaline phosphatase 200 for 6 weeks of age is normal, is not high. You have to remember that alkaline phosphatase level, the enzyme, different, the value different according to the age. Growing children, they have high physiological alkaline phosphatase. So here 200 is not high, it's physiologically normal level for 6-week-old infant. Parathyroid hormone was undetected. So here we have hypocalcemia due to low parathyroid hormone. So the diagnosis is hypoparathyroidism. B. Hypoparathyroidism. But why not A? Zudu hypoparathyroidism. Zudu, as you remember from my previous slides, is one of the subtypes of pseudohypoparathyroidism where we have parathyroid hormone is high. The same thing in D, Albright hereditary osteodystrophy, we have low calcium but high parathyroid hormone. Vitamin D deficiency here wrong. Why wrong? Because in vitamin D deficiency we should have high alkaline phosphatase and high parathyroid hormone, secondary hyperparathyroidism, opposite to what we have in the question. So the right answer is B, hypoparathyroidism. Hypoparathyroidism may be transient, may be persistent, may be inherited, may be acquired. Transient hypoparathyroidism, common in premature infants, neonates, or small for gestational age, while the permanent hypoparathyroidism could have plenty of causes. One of them, or the good example you have to read very well in pediatric endocrinology, George syndrome. George syndrome is one of the good examples of persistent hypoparathyroidism. 11-year-old boy presented with mental subnormality, facial dysmorphic features. As you could see in the photo, the child is having dysmorphic features. And when you look at his growth, you could say this is a child of 5 years of age, 4 or 5 years of age, not more than this. But his actual age was 11. So severe short stature, severe growth retardation, and mental subnormality. These combination, what do you think? Combination of severe growth failure, mental retardation, and facial dysmorphic features you are seeing. This is classical features of what? Could you tell me? Yes, Sanjit-Sakati syndrome. Sanjit-Sakati syndrome, where they have all of these features secondary to congenital inherited hypoparathyroidism. So the question, which diagnostic laboratory investigations you are going to order? IGF-1, growth hormone provocative test. This is not good for him because this is syndromatic short stature. In syndromatic short stature, we find normal IGF-1 and normal growth hormone level. Bone age, of course, will be delayed, but will not be diagnostic because delayed bone age is present in plenty of causes of short stature. So the diagnostic laboratory test for this boy is doing serum calcium and parathyroid hormone As I mentioned, these children will have primary persistent hypoparathyroidism. Hypoparathyroidism. Sanji-Sakati syndrome, autosomal recessive disorders, found exclusively in people of Arabian origin. It was described in 1988 from Saudi Arabia. So this syndrome, the description of this syndrome comes from Saudi Arabia, from Dr. Nadia Sakati. She is one of the excellent pediatric endocrinologists in Saudi Arabia. She was working in King Faisal Specialist Hospital, Riyadh. She's the one who described this syndrome together with her colleague, Dr. Sanjit. That's why the name of Sanjit-Sakati syndrome. And these children usually have the following association. Number one, severe growth failure of both intrauterine and extrauterine life. They have mild to moderate mental retardation. They have hypocalcemia seizure due to hypoparathyroidism. They have dysmorphic features include long, narrow face, deep-seated eyes, small eyes, peaked nose, large floppy ears, and micrognathia. 18-month-old infant is seen because his mother was concerned about his bilateral bowing of the legs, as you could see in the photo. In the history, this child was breastfed exclusively for 14 months. Exclusive breastfeeding for 14 months. Which one of the following laboratory tests are most likely to reveal? So what will be, first of all, your most likely diagnosis? Most likely diagnosis is nutritional ricket. So in nutritional ricket, which one of the following is true? You could find high circulating parathyroid hormone concentration, increased reabsorption of phosphate by the kidney, inadequate stimulation of bone resorption by parathyroid hormone, low conversion of vitamin D 225. The best answer is A. In nutrition ricket, one of the biochemical anomalies is high parathyroid hormone, what is called secondary hyperparathyroidism. Rickets refer to defective mineralization of the bone and cartilage in children, different from adult osteomalacia where only defective mineralization of the bone. Because in children, it develops in growing bone. Short stature is one of the association of rickets. Rickets could be due to low calcium alone, called hypocalcemic ricket, or low phosphate alone, called hypophosphatemic ricket, or in some conditions we could find both of them low calcium and low phosphate, what is called combined ricket. So either hypocalcemic ricket or hypophosphatemic ricket or combined rickets. In rickets, usually we have high parathyroid hormone if we are dealing with hypocalcemic ricket, while in hypophosphatemic ricket, parathyroid hormone will be normal. Calcium is important to investigate. Look for calcium, phosphate, parathyroid hormone, and vitamin D. Vitamin D, usually the routine test in rickets, 25 hydroxyvitamin D. Only we do vitamin D, 25 hydroxyvitamin D. 125 dihydroxyvitamin D is not routine investigation of rickets, unless we think of inherited rickets. So this child having nutrition ricket, No need to do 125 dihydroxyvitamin D. We'll do calcium, phosphate, alkaline phosphatase, parathyroid hormone, and vitamin D level. Vitamin D level means 25 hydroxy vitamin D. Another child with rickets, but different scenario. 18 months old boy was referred for further assessment of bilateral bowing. But the scenario here is different. This boy, father and mothers are first degree cousins, and whenever they mention in the question, any question you face in the exam, parents are first degree cousins, think about inherited condition. So here, because the father and mother are first degree cousins, we have to think of inherited rickets. As well in the scenario mentioned, the child, because of bowing of the legs, the doctors prescribed to him a good dose of vitamin D. The dose was 3,000 units per day, and the duration of treatment was 6 months. The father and mother were good compliance with medication. Despite with this, the bowing of the legs is more and more, is not recovering. So definitely we don't deal with vitamin D deficiency ricket. Because if it is vitamin D deficiency, we need only 2 to 3 months of treatment. Here, 6 months of treatment of good dose, good compliance, but despite improvement, he is deteriorating. The bowing is worsening. Laboratory is lab, calcium very low, phosphate is low as well. So we have here both low calcium and low phosphate. Alkaline phosphatase is high. Parathyroid hormone is high. So combined ricket of low calcium and low phosphate. What do you think the diagnosis? Yes, the diagnosis, as you mentioned, vitamin D resistant ricket. All these biochemical findings are classical in vitamin D resistant ricket. But the question, which one of the following investigation is diagnostic? Number one, do wrist X-ray to confirm active rickets. Yes, it's a good option, but it's not diagnostic for the cause of ricket. When we do X-ray in any child with ricket and we find the classical finding of rickets, but we do not differentiate for us what is the cause. So, despite is a good option, but not the true answer. Do 25 hydroxyvitamin D metabolite? Yes, we have to do. But here, because we are thinking of inherited rickets, doing 25 hydroxyvitamin D is not enough. Do both 25 and 125 dihydroxyvitamin D metabolite? Yes, this is the right answer. Why the right answer? Because here we are thinking of inherited rickets. But if the scenario, like the previous slide, nutrition ricket, definitely this is wrong. We cannot do both metabolites. But in this situation, in this scenario, this is the model answer. We have to do both metabolites of vitamin D. In any child, we are thinking that he or she is having inherited form of rickets. D. Repeat bone profile next day after correction of hypocalcemia. This is totally unacceptable answer. And this is what children with vitamin D resistant rickets looks like. And if you could notice in this slide, there are two findings will tell you about the diagnosis. What are the two important findings you could see? Could tell you this child is having vitamin D resistant ricket. Number one is alopecia. Yes. Alopecia is one important finding in vitamin D resistant rickets. And number two, if you are looking deeply in the chest, you could find a scar. What this scar was for? This scar was for central line insertion. Why central line insertion? Because the treatment of vitamin D resistant ricket is by giving high calcium, intravenous calcium, and high intravenous phosphate initially during the active stage of ricket, then to shift to high oral and high oral phosphate and calcium lifelong. This is the lifelong treatment, not with vitamin D, because vitamin D resistant, the receptor will not function with vitamin D, so we need to give high dose of calcium and high dose of phosphate lifelong, initially through central line and then shifted to oral. And this is part of the disease. They have, in addition to clinical signs of rickets, they have bone deformities. Vitamin D resistant ricket, type 2, rare autosomal recessive form of rickets. So far in the whole world, only 100 cases reported. Is associated with end organ resistance to 1,25-dihydroxyvitamin D because of gene mutation of the receptor, gene mutation of vitamin D receptor. Affected children, usually, they have nothing at birth, they normally at birth, and they develop signs of ricket in the first year or two of life, early presentation of rickets. Alopecia resulting from lack of vitamin D receptor activity within the keratinocyte develops approximately in 2/3 of cases. So 70% of cases of vitamin D resistant, they have alopecia. But 1/3 they don't have alopecia. So if you have a child with vitamin D resistant ricket with no alopecia, don't say we should have alopecia. Alopecia is common, but only in 70% of cases. And the remaining 30% cases, they don't have alopecia. If there is alopecia in vitamin D resistant ricket, that is called type 2A. If we don't have alopecia in vitamin D resistant ricket, that is what is called 2B, type 2B or subtype 2B. By this, we end third part of endocrine revision MCQ. I hope all the best for you. Good luck and see you in part 4 MCQs soon, shortly, inshallah.